Hello friends, this is Dr. Sana Fathima. Today I'll be discussing about infective endocarditis. Infective endocarditis is an endovascular infection of the cardiovascular structures including cardiac valves, atrial and ventricular endocardium, large intrathoracic vessels, and intrathoracic foreign bodies such as prosthetic valves, pacemaker leads, and surgical conduits. So endocarditis is the inflammation of the endocardium which is of infective etiology. See, we know that the heart and its major blood vessels, they are surrounded by three layers. Innermost is the endocardium, middle is the myocardium, and the outermost is the epicardium or pericardium. So this one is the infection of the innermost layer of the heart and its major blood vessels, and it affects the cardiac valves, which are your mitral valve or the bicuspid valve, aortic valve, tricuspid valve, and the pulmonary valve. And the prosthetic valves means these are the substitute valves which are used to replace a diseased valve in diseased cardiac conditions. Pacemaker leads are used to treat the heart blocks. These are the components of artificial cardiac pacemakers. And surgical conduits are the bypass channels which are used to treat blood flow obstructions. So two prerequisites are required for the infective endocarditis to occur. The first prerequisite is bacteremia, which means the presence of bacteria in the bloodstream, and the second prerequisite is the damaged endocardium. Bacteremia can result from many causes, the principal causes being poor dental hygiene, intravenous drug use, soft tissue infections especially in diabetics, dental treatment, intravascular cannulae, cardiac surgeries. And damaged endocardium can result from heart conditions such as valvular heart diseases, which includes mitral stenosis, mitral regurgitation, tricuspid stenosis, tricuspid regurgitation, and atrial and pulmonary stenosis and regurgitation also, and other congenital heart diseases like atrial and ventricular septal defects and patent ductus arteriosus. In these conditions of the heart, the normal laminar flow of the blood, which is unidirectional, changes to a retrograde and a regurgitant jet. So because of the turbulent jet, a high velocity blood column hits the endocardium vigorously and thus damages the endocardium. So bacteremia and damaged endocardium are the two prerequisites for infective endocarditis to occur. So we know that wherever the endocardium or the endothelia of the blood vessels are damaged, the coagulation pathway gets activated. So this leads to platelet and fibrin deposition here also in response to the damage of endocardium. And if there is superimposed bacteremia, there will be adherence of microorganisms to this platelet and fibrin deposition, and altogether this forms a structure which is known as a vegetation. This vegetation is a friable mass which is composed of platelet, fibrin, and microorganisms. This vegetation will form on the cusps of the valves of the heart, or it can also form in the major blood vessels. So the most common valves affected in infective endocarditis are aortic and mitral valves. In intravenous drug users, right-sided lesions are common, which means tricuspid and pulmonary valves are affected more, because the drug, as it is injected in the intravenous compartment, it reaches the right side of the heart, which is the receptive compartment of the heart, and so right-sided lesions are common in IV drug users. Now let us see the organisms which are implicated in the causation of infective endocarditis. The most common cause as a result of which infective endocarditis develops is the dental diseases and the dental procedures. This constitutes around 1/3 to half cases of infective endocarditis. And the causative organisms implicated here are the alpha hemolytic viridin streptococci group, which includes few species like Streptococcus mutans, Streptococcus sanguinis, Streptococcus oralis, and Streptococcus mitis. In prolonged indwelling catheters or intravenous drug users, the causative organism in most of the cases is found to be Staphylococcus aureus. In genitourinary diseases or procedures like hysterosalpingography, cystoscopy, Enterococcus species are mostly implicated in the causation of the disease process. To be more specific, Enterococcus fecalis is most responsible. And in patients undergoing native and prosthetic valve surgery, within 60 days of the surgery, which is termed as early onset of infective endocarditis post-surgery, the organisms which are responsible for causation are Staphylococcus aureus and Staphylococcus epidermidis. In late onset, that is more than 60 days of the surgery, Streptococcus viridans species and Staph aureus are mostly responsible for the disease process. In soft tissue infections, Staphylococci are mostly responsible for the disease process. So the criteria to diagnose infective endocarditis was put forth by Duke, which is modified Duke's criteria. It includes 4 major criteria and 6 minor criteria. So the major criteria go like this. First, a positive blood culture for infective endocarditis, which is defined as recovery of a typical microorganism from 2 separate blood cultures in the absence of a primary focus. Typical microorganism means the organism isolated from culture should be known to cause infective endocarditis, and separate blood cultures means they have to be obtained at a separate timing and ideally from the different venipuncture sites. The same site should not be poked again for obtaining the sample. And the organisms which are isolated and can be labeled as a positive blood culture are your viridin streptococci, community acquired Staphylococcus aureus, Enterococcus species, Streptococcus bovis, Hayseck group of organisms, and Abiotropia species. Hayseck stands for, H stands for Haemophilus, A stands for Actinobacillus, C stands for Cardiobacterium hominis, E for Eikenella corrodens, and K for Kingella kingae. These are atypical group of microorganisms which are known to cause infective endocarditis. It is difficult to isolate on normal culture. They require special culture media for their isolation. The second criterion is the persistent positive blood cultures. Now, why this word persistent is being added to this criteria? This means the recovery of the microorganism should be consistent with endocarditis and it should be positive in the blood samples which are obtained 12 hours apart, or 3 to 4 closely drawn samples within a span of 1 hour period should show the same growth of the organism. Like if we are obtaining closely spaced samples, 3 to 4 samples within a span of 1 hour duration, all the 3 to 4 samples should isolate the same organism which is consistent with the causation of endocarditis. And the third criteria is the positive serological test for Q fever. Q fever is caused by Coxiella burnetii, which fails to grow in normal blood cultures. Hence, immunofluorescence assay has to be done to diagnose this Q fever. And the phase 1 immunofluorescence assay should show IgG titers of more than 1:800 to fit into this criteria. And the fourth criterion is the echocardiographic evidence of endocardial involvement in the form of either you have to see an oscillating intracardiac mass on the valve or supporting structures or an implanted material in the absence of an alternative anatomical explanation to it, or you should find on echo an abscess or a new partial dehiscence of a prosthetic valve. Dehiscence means splitting or bursting, or a new valvular regurgitation. Minor criteria are like this. There should be a history of a predisposing heart condition or intravenous drug use. Predisposing heart condition means the patient should have congenital heart diseases or valvular heart diseases or some cardiac surgical history like pacemaker implantation. And the second minor criterion is the presence of fever, temperature of more than or equal to 38 degrees Celsius or 100 degrees Fahrenheit. Then vascular phenomena should be present like major arterial emboli or septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhages, conjunctival hemorrhages, or Janeway lesions. Janeway lesions are the painless hemorrhagic lesions which are most commonly seen on the palms and soles, as you can see in this image. Major arterial emboli includes your cardiovascular, carotid, or the cerebral emboli also, and septic pulmonary infarcts infecting the lung. Aneurysm is nothing but a dilatation of an artery which is due to the result of damage to the vessel wall by an infection. Mycotic, it doesn't mean only fungal here, it can be caused by bacteria also. This is just a misnomer. And intracranial hemorrhages can occur as a result of emboli. Conjunctival hemorrhages can also occur as a result of obstruction to the blood flow. The fourth minor criterion is the presence of immunological phenomena. Here what happens? The antigen-antibody reactions take place and the antigen-antibody complexes get deposited in the organs, like the presence of glomerulonephritis, Osler's nodes, Roth spots, and the rheumatoid factor positivity. Glomerulonephritis is the inflammation of the kidneys. To be more specific, it is the inflammation of the functional unit of the kidneys, which is the glomerulus. Here, this glomerulus gets affected as a result of antigen-antibody complex deposition, thus compromising the renal function. And Osler's nodes are tender, purplish pink colored nodules having a pale center which is found on the pulp of fingers. Here you can see in the image. And Roth spots, these are multiple retinal hemorrhages having a white center. You can see in the image there are many hemorrhages scattered over the retina which is having a pale center. But these hemorrhages are not specific for infective endocarditis. They are also found in other conditions like leukemias and blood transfusions. And the fifth minor criterion is the microbiological evidence, that is a positive blood culture or a serological evidence of an active infection with an organism that can cause infective endocarditis. Now the last minor criterion is the 2D echo findings, which are consistent with infective endocarditis, but they are not sufficient to meet a major criteria. Now, the definitive diagnosis of infective endocarditis is established when a microorganism is demonstrated by culture of a specimen from a vegetation, embolism or an intracardiac abscess, or active endocarditis is confirmed by histological examination of the vegetation or intracardiac abscess, 2 major clinical criteria, or 1 major and 3 minor clinical criteria, or 5 minor criteria are met. When these are established, then only a definitive diagnosis of infective endocarditis is made. Now let us discuss the clinical course of this disease. It can present in 2 forms. Either it can present as an acute fulminating infection which requires immediate management, or it can also present as chronic or subacute illness with low-grade fever and non-specific symptoms. Now let us see the symptomatology clinical features. Pyrexia, malaise and arthralgia are non-specific features of this disease. Pyrexia means fever, malaise is the feeling of discomfort, and arthralgia means joint pains. Murmurs and cardiac failure. Murmurs are nothing but abnormal cardiac sounds apart from your heart sounds S1, S2, S3 and S4. They say that the presence of a new murmur in a pre-existing valvular heart disease points more towards the diagnosis of infective endocarditis. And the onset of cardiac failure is one of the clinical features of infective endocarditis. Hematuria, which is the passage of blood in urine. Cerebral emboli, giving rise to stroke and infarctions. And petechiae, these are small subcutaneous skin hemorrhages. Splinter hemorrhages are the hemorrhages which occur under the nail beds. you can see in the image, that is the splinter hemorrhage. It is an irregular, purplish, occurring specifically under the nail beds. So the investigations which are done in cases of infective endocarditis are first blood cultures and echocardiography. These are for the diagnosis of disease itself. Like we have seen in the major and minor criteria, many criteria were pertaining to the blood cultures and echocardiographic features only. And the other investigations are to assess the magnitude of the complications and to assess the fatality and to prognosticate the patient. So these are chest x-ray. This is done in cases of cardiac failure and pulmonary embolism. Renal function test and urine analysis. This is done to know the values of serum electrolytes, sodium, potassium, chloride and bicarbonate, and also urine analysis for presence of hematuria, and blood urea and serum creatinine in cases of glomerulonephritis. And the inflammatory markers which are assessed are ESR and C-reactive protein. These inflammatory markers, they help in assessing the response to treatment. Like during the active course of the disease, these markers will increase. During a remission phase, these markers will come down, and again during a relapse, these markers will increase. So this is helpful in assessing the response to treatment. Management, the mainstay of treatment is the medical management only. Prolonged course of antibiotics to 4 to 6 weeks duration has to be given to the patient. And before starting the antibiotic treatment, blood cultures should be taken so that your results will be unaltered. So this is known as the empirical antibiotic treatment. You should not wait till the blood cultures turn out to be positive. After the blood cultures isolates a specific organism, you can start your evidence-based treatment. But before that, empirical treatment has to be instituted depending upon the symptomatology. But before starting empirical antibiotic treatment, it is advisable that you draw the blood cultures. So blood samples, So the sequence is like that. So you should isolate the blood sample first, then start the empirical antibiotic treatment, then wait for the blood culture to show the specific organism. If an organism is isolated, then your treatment should target that specific organism. The advocated antibiotic regimens for cases of endocarditis goes like this. Like in cases of clinical endocarditis, when the culture results are still awaited, but there is no suspicion of staphylococcus organism, or if it's a culture proven streptococcal endocarditis, then for both these scenarios, the treatment is the same. That is penicillin 1.2 gram every 4th hourly along with gentamicin 80 milligram every 12th hourly. In the second scenario is like this. In cases of suspected staphylococcal endocarditis, what we give is vancomycin 1 gram every 12th hourly in combination with gentamicin 80 to 120 milligram every 8th hourly. This was in a suspected staphylococcal endocarditis. Now, what if there is culture proven staphylococcal endocarditis? Then what we give is vancomycin 1 gram every 12th hourly or flucloxacillin 2 gram every 4th hourly, or a combination of benzyl penicillin 1.2 gram every 4th hourly with gentamicin 80 to 120 milligram every 8th hourly. In cases of enterococcal endocarditis, culture proven, we give a combination of either ampicillin or amoxicillin 2 gram every 4th hourly with gentamicin 80 milligram 12th hourly. All these antibiotic regimens are adapted from British Society for Antimicrobial Chemotherapy guidelines. Most patients, they start responding within 48 hours of initiation of antibiotics. The signs of response which you look for in the patient are, first is the resolution of fever, and there will be reduction in the serum markers of infection, that is your ESR and CRP will show a lower value, and there will be relief of systemic symptoms of infection also. But in case if there is a persistent fever, there can be 4 possibilities. Persistent fever implies there can be a perivalvular extension of the infection and possible abscess formation. which means a progression, and it could be a drug reaction. So you can diagnose when drug reaction is suspected, you can withhold all the drugs and see for the resolution of symptoms. And third possibility could be a new onset hospital acquired infection. Since you hospitalize the patient, there can be other infections like urinary tract infection, which also manifests with fever, and venous access site infection, which again manifests with fever. And there could be presence of a pulmonary embolism, like development of a secondary right-sided endocarditis. You need not require to know this in detail. Just you remember the persistent fever implies these 4 conditions. Surgery is usually not advocated in all the cases, only if there is no response to medical treatment, that too when you continuously give for a period of 4 to 6 weeks. In spite of this, there is no response in the patient, then you consider taking this patient for surgery, that too only in selective cases with no other morbidities, no other systemic morbidities should be there. Surgery is not done easily in these cases for the fear of spilling this vegetations during the surgical process. So this infective foci can shift from the primary focus to secondary focus also. For this reason, surgery is not done now very frequently in these cases. Most cases show good response with medical management only. Prevention. The European Society of Cardiology, ESC, has given 3 high-risk group categories for which antibiotic prophylaxis should be advocated whenever these high-risk individuals undergo high-risk procedures. So according to the European Society of Cardiology, ESC, the 3 high-risk categories are: first category includes the individuals, those who have prosthetic valves, and second category includes those individuals who had a previous episode of infective endocarditis, and third, those with uncorrected cyanotic congenital heart diseases or who have received palliative shunts. And according to AHA, the American Heart Association, even cardiac transplant and valvular heart disease patients are also considered as having high risk. So these high risk individuals, when they undergo high-risk procedures like dental procedures which involve manipulation of the gingival or periapical part of the teeth or perforation of the oral mucosa, should be given a strict antibiotic prophylaxis to prevent the onset of infective endocarditis. The clinical pearl which is related with this topic is the practice of percussion in cardiovascular system examination has become obsolete for the fear of dislodging the vegetations of infective endocarditis or plaques of atherosclerosis while percussing. Thank you all for your patient listening. All the best.